Here's a resus case for review, basic bread and butter stuff, just to show you how we apply the concepts. EMS is calling. They say they have a 45-year-old man with severe shortness of breath, blood pressure 240 over 120, heart rate of 120, respiratory rate of 32, and a saturation of 88%. Lungs have decreased breath sounds and wheezing. Sinus tach on the monitor, and too diaphoretic to get an IV. The guy shows up in resus. He's tripoding, very diaphoretic, severe respiratory distress. These are his vitals. His saturation on a 100% non-rebreather is 92%. Well, what are we going to do? We got a guy in extremis that just came in. We're going to think about the ABCs. That's what we're going to do. Airway, sitting upright, few words, very focused on breathing. That's a yellow. Breathing, oxygenation, 92% on 100% in severe respiratory distress. That's yellow, turning orange. Ventilation, still upright and alert, but can't really give him a green, so let's go yellow. All right, circulation. He's hypertensive, tachycardic, and diaphoretic. That's a threat in a very different way than we're used to. This is not a hypotensive guy, but circulation is definitely threatened in a whole new way. Your exam. Severe respiratory distress, diaphoretic, crackles to the apices with wheezing, heart tachycardia with murmur, abdomen benign, extremities good perfusion without swelling, neural without deficits. What is your working diagnosis? Your problem list includes severe respiratory distress, hypoxia, and severe hypertension. Well, let's consider the fact that he has severe respiratory distress and go from there. Magic question number 1. Does he need to be intubated now? Absolute indications: failure to oxygenate, failure to ventilate, failure to control the airway? Not yet. Magic question number 2. Can you reverse it? Hypoxia, hypertensive pulmonary edema, pneumothorax, asthma, allergic reaction. Does this guy have one of these? Yeah, he probably does. So you need to support the breathing. In his case, probably BiPAP would be the next one to try before you actually consider intubation. Can he run? Well, maybe he can run for a little bit if you act quickly. Pathophysiology here real quick. You got a severe hypertension, which causes increased ventricular pressures. These pressures are transmitted into the lungs. You get pulmonary hypertension, leaking in the alveoli, lungs fill up with fluid, an epinephrine surge because you're drowning. That causes more hypertension, and everything gets worse. It's a circle. What do you got in your arsenal? Well, first you're going to maximize oxygenation. When you give them a lot of oxygen, that's great for them because that's a pulmonary vasodilator. Actually, the strongest pulmonary vasodilator there is. Then there's nitroglycerin. That's a coronary vasodilator, and it decreases the epinephrine surge when the heart has better supply. The supply-demand ratio turns in their favor. Morphine is a coronary vasodilator as well. Decreases that epinephrine surge and helps them to deal with the situation better. Lasix is a pulmonary vasodilator primarily. It's a late diuretic, but realistically, these patients aren't usually fluid overloaded. This is flash pulmonary edema, so diuresis is not necessary. So how about nitroglycerin? You can give the patient multiple sublingual nitros at the same time before the IV is even established. We put them under the tongue like pearls when I was a resident. 2 or 3 actually. Works pretty nicely to get it going and the patient decrease their symptoms. Then, once you've done the sublinguals and you actually get an IV and everything going, you want to start your drip at 40 or more. Starting less than that is kind of ridiculous when you've already put pearls under their tongue and gave them a pretty big bolus. But start at 40 and then titrate up quickly. If no resolution by 200 micrograms, you may still need to add nicardipine, but this is rare. The way the nitroglycerin works is illustrated in the picture at the bottom. From 0 to 100 mics, you get a good response to your dosing. After you get past 100, that kind of flattens out, and you're not getting an increased response with increased dosing. At 200 micrograms, that really flattens out completely. So if you get to 200 and you don't get anywhere treating the patient, you might want to consider adding nicardipine. Act quickly. It's very important. This guy can't run at max for any significant duration of time. Realistically, if he's got a blood pressure that high and he's still alive and still maintaining that blood pressure and his heart's still working, he probably has an ejection fraction of greater than 50. But nobody can function drowning like that for very long and working that hard to breathe. You can usually resolve this with aggressive treatment without intubation in the majority of cases, but you gotta act quickly. Decrease that LV strain, and half the battle is won. If you get that blood pressure down enough that they move back to their autoregulatory zone, as seen in the picture on the bottom, you've done a lot of good. That's it. See you next time.